Welcome, everyone, to another Prodigy EMS webinar. We are pleased to have you join us today for this important topic, traumatic brain injury, essential management, and emerging therapies. Thank you to LifeFlow for supporting this essential education today. I am Hillary Gates, Director of Educational Strategy at Prodigy EMS. You will be receiving one CE credit for today's webinar, so be on the lookout for an email from us later. And we encourage you to share the recording of this webinar that will be posted on our site. We are excited to have our friends and colleagues, Doctors Mark Piehl and Peter Antevy, teaching us today. We look to these formidable clinicians for guidance on many aspects of out-of-hospital medicine, especially for pediatric pearls. Today, Mark and Peter will revisit the core lessons from the EPIC trial that established guidelines for managing TBI. They will underscore the importance of early interventions because we know that fundamental and precise resuscitation practices can preserve brain function, prevent secondary injury, and save lives. Mark and Peter will also share perspectives on emerging therapies and ongoing research that may further enhance outcomes for our patients. So on to the webinar. While you are watching, feel free to post questions in the chat and the Q&A, and we will get to them at the end. Thank you for being here, and take it away, Mark and Peter.
All right. Thank you, Hillary. It's totally a privilege to be here. Peter and I want to talk to you today about a topic we're both passionate about, which is traumatic brain injury, particularly in kids, but we're going to broaden the scope to all ages and how we can apply basic management principles in the field to bring about the best outcomes in our patients with traumatic brain injury. And then we're going to talk about some emerging things, some of which are here now and some of which are coming to us in the near future. So Peter and I together will give this talk. You all know Peter. I'm a pediatric critical care doc in North Carolina and a critical care transport medical director at Wake Med. And kind of my origin story and the reason I have interest in this topic is a patient who had multi-system injury, including traumatic brain injury, that we flew in years ago to my hospital and who sadly ultimately bled to death. And the nursing team and I left the room and thought, we could have done this better. How could we do this better? And that led to really a change in my outlook on emergency and critical care and transport medicine, and really changed my career in many ways and made me want to focus on improving the care of severely injured children and adults. And so this topic today relates back to this original patient. We want to know, how can we best take care of someone in this situation to give them the best possible chance of survival? So quick disclosure, I am the founder of 410 Medical, maker of the LifeFlow device. My own hospital is an owner of that company. I have a lot of Department of Defense grants to develop trauma resuscitation technologies, but my first love professionally is patient care, critical care, teaching, and innovation around those topics. So just be aware of those disclosures. We're going to start with a case of a 14-year-old who ran his dirt bike into a telephone pole. And at the scene, his friends described that he was thrown off the bike, sat up, and tried to remove the helmet with blood pouring out of his helmet. As soon as the helmet came off, he collapsed and was unresponsive. The EMS team found him when they arrived with a GCS of 3, tachycardic and hypertensive, interestingly, initially, and they provided bag valve mask ventilation en route, as well as direct pressure to the massive skull fracture and open brain that they saw at the scene. So this is a devastating, potentially devastating traumatic brain injury. Several of my partners, ER docs and ICU docs, found him apneic on arrival and decided to intubate him immediately, which is an understandable first reaction to that situation. It turns out, however, he was hypovolemic from blood loss and became hypotensive immediately after intubation. Thankfully, the team was able to administer a liter of crystalloid and then a couple units of whole blood right there in the trauma bay, got him resuscitated, resolved his blood pressure, brought his heart rate down, shock index now normal, and he got off to the OR where he received more resuscitation. So Focusing here on a couple of elements we're going to talk about in a minute are the things that he needs are normalization of his vitals, SATs, end-tidal CO2, and blood pressure. That team had to work very hard and very quickly to get those parameters normalized so that they would limit subsequent brain injury. Thankfully, because of their quick work and the work of the neurosurgeon, he was extubated the next day in my ICU and discharged neurologically normal 5 days later. So immediate treatment of all of the physiologic derangements he had, apnea, hypotension, hypercarbia, allowed this child, thankfully, to recover quickly. What he needed was perfusion and oxygenation restored to his brain as quickly as possible. So he got good mask ventilation early, then he got good in generally good hemostatic resuscitation, meaning resuscitation with whole blood the minute he hit the door when he was hypotensive, which allowed nutrients, oxygen, perfusion to be restored to the brain and allowed the brain to recover. So let's think about what our priorities are when we encounter any patient, child or adult, with a traumatic brain injury. And I understand we can't initially see into the skull to know what's really going on in there. But if someone's had a high impact injury or a skull fracture like we saw in this patient, we can be pretty assured that there is bruising and or hemorrhage around the brain. And in this image, we see both. We see the center of the brain with a significant impact injury and then some subdural hemorrhage collected around it. And that brain that's been directly impacted may now be non-viable and not survivable. But what we have the opportunity to do is preserve the surrounding brain, which still can differentiate itself either way. It can die or it can live. And so a great analogy I like to talk about is what's called the penumbra. If you look at an eclipse, a solar eclipse, we have the moon on the right with a little rim of sun just peeking around. Think of that moon as the dead brain. It's not coming back. The starry sky beyond is all healthy brain. And then there's this little window, the yellow circle you see on the image of the brain, which has a choice. It can live or it can die. And that can depend on our interventions, maintaining adequate perfusion, resuscitating that patient well, ensuring adequate airway control and oxygenation, and making sure we provide effective ventilation. So our job as clinicians, whether pre-hospital or in the ED or in the ICU, is to maintain the most normal vital signs we can and focus on them so that we can restore that brain to health that has the ability to differentiate into non-viable tissue or healthy brain tissue. So the EPIC TBI trial, which was published several years ago, is a fascinating look at how we can manage TBI, severe TBI in particular, effectively in the field. And their conclusions were that there are three big things they call the H bombs, which we need to avoid. Hypotension, as you saw in my patient, hypoxia, which certainly he was going to have if he was apneic, if we didn't provide effective ventilation. And we also need to avoid hyperventilation, which itself can diminish cerebral perfusion. Those three simple goals, if we can achieve them, we can achieve the best outcomes in our patients. So the basic parameters to achieve are normal blood pressure, so over 90 in an adult, and probably over systolic blood pressure of 80 plus twice the age in a kid. Avoid hypoxia, so SATs over 90, and avoid hyperventilation. This is one that we perhaps neglect the most, is not paying attention to how effectively we're ventilating and that we're not overdoing it. Remember, a low end-tidal CO2 means we're hyperventilating and we're diminishing cerebral perfusion as we do that. So they recommended that we try to achieve a respiratory rate in general of 25 in infants, 20 in kids, kind of school age to early teenage kids, and 10 in adults to avoid hyperventilation. And ideally, we'll always have an end tidal running so that we can target our ventilation to that end tidal CO2. So some of the outcomes of the EPIC TBI I think are worth pointing out. They basically looked at over 10,000 patients with multisystem trauma and severe TBI, and they found that patients had the lowest mortality if the paramedics were able to achieve higher systolic blood pressures. In fact, the lowest mortality was achieved at 130, which is something we probably rarely achieve in the field if someone's initially hypotensive. And they suggested that the systolic blood pressure threshold that we tend to think of as hypotension needs to be revised for TBI patients up higher, probably 110 or so. And they also pointed out, which is intuitive, that the longer the hypotension persisted and the greater the depth, the increased risk of mortality. And then, in fact, no minute of hypotension is tolerable. So my patient that I presented to you had probably 3 to 5 minutes of hypotension. Thankfully, he did well, but any longer than that, and he might have had a worse outcome. And then we know that in children with severe TBI in particular, the earlier we treat that hypotension, the better the survival is. That study was called EPIC for kids. So I'm going to zip through the actual EPIC TBI slides. These are available to you on the web. If you Google EPIC TBI, you can download this PowerPoint. And they recommended aggressively preventing, watching for, and treating hypotension. So in kids, they recommended a fluid bolus of 20 per kilo for anyone with a pressure under 70 plus twice the age, repeating 10 per kilo boluses as necessary to keep that above the threshold. Now, Peter and I are going to talk about the emerging trends of pre-hospital transfusion, which if this child's bleeding, that's the volume that they should be receiving, and potentially plasma, which many agencies are starting to carry as a volume expander. And that may actually be a better choice than crystalloid in these patients. But we know most of you at this point are still going to have crystalloid. And so it's very reasonable in a patient with traumatic brain injury and hypotension to administer 20 per kilo of fluid. In adults, they recommended an initial bolus of saline of 1,000 mils and then repeating doses of 500 to keep the systolic over 90. This number is probably now going to be revised to 110 or greater, trying to keep that blood pressure higher so that we maintain better cerebral perfusion. Next, we want to aggressively prevent and treat desaturation. So our patient got an oral airway placed, a BVM, and gentle ventilation as he was riding in to maintain sats over 90, which they did successfully. This applies to all patients with potential or known TBI. They also pointed out there was no such thing as hyperoxygenation, giving too much oxygen. We probably don't want to do that for hours on a ventilator, but in the moments we have in the EMS environment or in the ED, it's probably fine. And we should pre-oxygenate someone who's not hypoxic. Let's go ahead and have some oxygen flowing in anyone with severe TBI, meaning by cannula or face mask. And then we discussed the ventilation rate so that we maintain a normal ventilation. And they also recommend, interestingly, that someone should be watching that end tidal and pointing out to the patient, to the provider on the BVM, hey, slow down, speed up a little bit. We need to keep that end tidal completely in the normal range. And so I have an image here from my own team. This is one of my partners where we're managing a severe traumatic brain injury patient together. And what do you think he is solely focused on that monitor at the moment? It is the end tidal. David is ventilating that patient gently, and he's going to keep the end tidal just about 35 the whole time of that CAT scan because we know overventilation could cause diminished cerebral perfusion in this child. So, summary of the TBI findings were that if EMS teams adhered to these principles, they actually ended up having to intubate patients less, despite having greater severity of injury of TBI, meaning they were likely to achieve BVM only management, just like in my patient. That was effective. They had greater likelihood of maintaining normal SATs, of reversal of hypoxia if it was found. They had greater likelihood of receiving adequate fluid boluses and reversing hypotension, and they had lower rates of hyperventilation. So to the extent we're thinking about these things ahead of time, practicing them, we'll actually perform them in the field and bring about better outcomes for our patients. Quick reminder, in pediatric trauma, hypotension, of all those things, if I could treat them, it would be the main parameter to think about and treat. Hypotension is the single biggest risk factor for death in a child who has traumatic injury. And that's especially true if they have TBI, because every minute of hypotension is going to worsen their outcomes. What about the concept of permissive hypotension? You've heard about this. We talk about it a lot in non-compressible torso trauma, meaning an injury inside the belly or thorax that we can't compress. It's said that we should keep systolics in the low normal range with fluid or blood boluses to around 80 to 90. and then subsequent boluses to keep the pressure there. I think kids likely need a minimum systolic with TBI of 80 plus twice the age. Some people think it's 90 plus twice the age. Peter, I don't know if you have an opinion on those two ranges in uh, your agencies.
Yeah, the blood pressure numbers, I like what you have up here on the slide, and I think that we have to really move people toward that elevated number. I have moved my agencies to higher values as you have here on the screen based on the data that you just presented.
Good. And so just a quick reminder, what is hypotension in a child? It's something less than 70 plus twice the age. For any child between the ages of 1 and 10, 70 plus twice the age. Simple to remember. A lot of the newer sepsis protocols are relying on mean pressure. I don't think I will ever convert my thinking to mean pressure in a child with shock. Systolic is a simple way to think about it, and it then allows us to target a minimum systolic when we're resuscitating. So at least 80 plus twice the age, if not 90 plus twice the age in severe TBI, or 110 in an adult. And then we're going to give blood, fluid, plasma, whatever we have available to maintain that perfusion and blood pressure in small boluses as we are transporting the patient. And remember, also, just as you saw in the patient I presented you, hypotension is a risk factor for peri-intubation arrest. So thankfully, our patient didn't arrest, but he'd lost a lot of blood. He got positive pressure ventilation with an ET tube, and in fact, he got hypotensive, which could have further worsened his outcome. Thankfully, it didn't in this case. So if all we have available to us is a crystalloid, what should we use? We hear a lot about lactated ringers or balanced solutions in sepsis. What about in trauma? Don't use LR. And the reason is it is a hypotonic solution. In the child you saw in the CAT scanner, she had acute increase in intracranial pressure. And what do we administer to her? Hypertonic saline, 3% saline. You're probably not going to be carrying that, but your fluid bolus, if you're going to use a fluid in any patient with TBI and hypotension, should be normal saline. And in small doses, this is both effective and safe. Or, as Peter's going to talk about shortly, you could use plasma, thawed plasma, uh, fresh liquid plasma, or potentially freeze-dried or spray-dried plasma, which is something that's coming in the near future. So this is potentially the future of effective TBI and maybe even sepsis resuscitation. And I'm going to turn it over to Peter to discuss some of these new innovations.
All right, Mark, excellent presentation and great review of EPIC and exactly what we need to look for in both adult and pediatric injuries. A little bit of background. So my name is Peter Antevy. I do have a disclosure as well that I'm the founder of Antevy, which we will not talk about today. I do want to talk about a case that we recently had, because this really, for me, encompasses everything that we're talking about today, which is a guy who is on a motorcycle. He hits a car at the intersection, 7 o'clock in the morning. And if you can see on the right-hand side where our engine is, and then you can see where the blood stain is, that's how far in the air he was ejected. Had a helmet on, but he had a head injury and he had multi-system trauma. This is the guy who's bleeding, obviously bleeding. He has TBI, he has multi-system trauma. And whether you have blood or not, you have to stop the bleeding. And the question is how to do it when it's a non-compressible hemorrhage. So the question for you is, how do you optimize clotting in EMS? And the first thing I want to talk about is TXA. And hopefully all of you are using TXA. Let me go back into a little bit of biochemistry to really quickly talk about how the body works. The image I want to show you is on the right-hand side, which is a spider web. That's what the body does when a trauma happens. So at the very top, you see the trauma happening. It goes to this whole cascade of things. And there you go, the spider web or this cross-linked fibrin clot is created. Now, what's interesting about what the body does, as it's creating spider webs, it's actually tearing them down at the same time. So it's this process of building and tearing down. The body does that on purpose. And here I show this image of this guy who's, he's not tearing down the whole spider web. He's kind of tearing down pieces of it. This is what you see at the bottom here. And this is called plasmin. So plasmin comes into that spider web and it starts peeling it away slowly. It starts with plasminogen. It goes to plasmin. and that's how you end up degrading the fibrin. So where does TXA act? Very simple. TXA does not allow the body to break down clot that's already been formed. It leaves the initial spider web that's been created intact. So it's not creating new clot, very important. So a lot of people think, oh, it's going to create an increased clotting in this patient. It doesn't. It just doesn't allow the degradation of the current clot. And that's important when you have someone who's trying to bleed to death and you're trying to tell the body, maybe we shouldn't be so aggressive in tearing down the clot you just built. Very important. Now, does TXA work in trauma? Big studies. I'll go through all the studies here very briefly, but CRASH-2 was the very first study. And again, how do people die from trauma? They have hemorrhage, they can have brain injury, organ failure. But let's talk about CRASH-2. Very big study, 40 countries, hundreds of hospitals. And this is a randomized controlled trial. And they're basically asking the question, does this drug called TXA that's inhibiting the formation of plasmin, that's preventing the breakdown of this clot, actually save lives? And when you look at these studies, especially the ones that were done many years ago, you have to understand, when was the drug given? How long after the injury was it given? How was it administered? And it turns out that all those things, now we may know a little bit better, may have had an impact on the outcomes. So the cool thing about CRASH-2 is, with over 20,000 patients randomized, they had an enormously good follow-up, right? Look at that, almost 100% follow-up. That's almost never happens. The bottom line on this one, look at the red numbers, basically. If you look at the number of deaths in these groups, you clearly had, less than 200 people did better with TXA, but they did better, right? So there was an absolute difference in the TXA, meaning that TXA reduced all-cause mortality with an absolute reduction of 1.5%. So what I tell people all the time with TXA is, the reason these studies had to be this big, tens of thousands of people, is because TXA at the end of the day is not a silver bullet. It's not this miraculous drug that's going to save half the people. You have to give it to a lot of people to save a few, and that's okay. It's very cheap, very inexpensive. But also remember that the way this study was done, they gave TXA within 3 hours, but then they gave a gram over 10 minutes, and then they gave another gram over 8 hours. So they didn't really give a big dose up front, and things have changed since the publication of this study. What's interesting, when they go back and actually look at this study, you can see this is an odds ratio plot, meaning that solid line, vertical line right in the middle. Take a look to the left. If anything is to the left of that, it favors TXA, but you can see that the people who got TXA early, like by EMS early, within the hour, they did much better than the people who got it within 1 to 3 hours. And clearly, you can see that if you give it after 3 hours, you actually cause harm with TXA. So time matters. It turns out that also dose matters, which is something that we've learned subsequently to that. And again, when you look at the information, there's a 32% relative reduction in bleeding deaths when TXA is given within the hour, but the overall number of patients is not that significantly different. So TXA works. It's not a silver bullet. Again, the other thing to know is that TXA does not cause an increase in clotting. That's what this paper showed here. So the bottom line is, for everyone to know, is TXA is an EMS drug, and it does reduce deaths that are caused by bleeding. It does reduce deaths caused by traumatic brain injury. And I showed you the mechanism of TXA, but actually, Mark, I want to bring you in because you actually mentioned this to me earlier, which is that TXA may have a mechanism of injury that's not just the plasmin that we talked about.
Correct. So there's some suggestion that TXA independently improves outcome from traumatic brain injury, independent of its effects on clotting. And that seems to me to be pretty exciting. I think in CRASH-2, Peter, they showed improvements in TBI outcomes, though not among patients with severe TBI.
And I'm going to get to that next. Yes, you're exactly right.
And, yet is the question that we're going to have in our agencies and our EDs is, okay, I encounter that patient that you showed me on the street, Peter. Let's say he wasn't bleeding. He purely has a TBI. Do we give TXA still in those cases? First indication
Absolutely.
is hemorrhage. Yes. Hemorrhage plus TBI. Yes. Do we give it for isolated TBI? I think the jury is still out on that question. It may have independent benefit, but I don't know that we know the answer to that yet.
Right, but I would say that there's no harm in doing it.
Correct.
And when you look at the Marty Schreiber study, I do think that we should be giving TBI patients TXA. And again, I'll go through the crash tree here in a minute. But first, before I do that, let me show you just I know it's a busy slide, but I want to just show you that crash 2 we just talked about. Again, you saw that small decrease in mortality, a very big study. Then there was the Matters 2012 that was done earlier. They also showed that mortality, there was a significant mortality difference. That was the second one. Then there's 2 EMS studies, which interesting showed no difference. But look at how the TXA was given. 1 gram over 10 minutes, and then they gave another gram over 8 hours, where now I think most of us have moved to 2 grams right up front.
And Peter, I don't know if you'll mention this, but the Woman 1 and Woman 2 trials showed benefit in maternal hemorrhage also when given earlier. So those were like 20,000 patients as well. So a lot of good evidence for proven mortality when we have severe hemorrhage of all types.
Agreed. And again, remember I told you that TXA causes such a small difference that you need a lot of patients. And perhaps that's why these 2 studies at the bottom showed no difference, because
That's a good point.
the sample size just wasn't big enough. And again, if it causes no harm, it's dirt cheap, then there's really no reason not to give it, especially now that we're giving it differently and earlier. Okay, crash 3 is what we're going to go to next. And again, crash 3, they looked at TBI. And you could see here that when you look at, again, this odds ratio plot, you could see here that that line, the little whiskers off that big square box, crosses the 1, which means that it's not statistically significant. However, when you looked at the patients and you looked at them early within the hour, then it does make a difference. So it's very clear that it's dosing dependent, it's time dependent, but as an EMS medical director, I would say that this is EMS dependent, and that's kind of where we're sitting. So let's talk about TXA dosing. We've just been mentioning it. It's 2 grams up front. Some people are giving it slow IV push. Other people are putting it in a 50 bag and letting it run right in. Some people are giving it intramuscular. There's data on all of that. The key is give it quickly. Don't give it after 3 hours. And I think that's the biggest key that you can have right there. Now, I want to quickly move into calcium, because if some of you may have keenly recognized my slide from before, let me show it to you right now again, that I was showing you TXA, but did you notice all the areas where calcium fits into the formation of that clot? It's super, super important, because it turns out that trauma causes hypocalcemia. The trauma itself causes hypocalcemia, right? And again, this is the death diamond. You can see that hypocalcemia is a big thing. And you can see that there's hypocalcemia related to the trauma itself that a lot of people don't even talk about. And then there's hypocalcemia that's caused by the treatment of the trauma, AKA whole blood, right? And we know that if you have severe hypocalcemia, an ICAL of less than 0.9, we know that you have an increased cause of death. Now, some people are also worried that hypercalcemia will do the same thing. This all still needs to be fleshed out in the literature. You need calcium also to constrict your vessels. Why would you want to constrict your vessels in trauma? Not to bleed out. Calcium matters with clotting. Calcium matters with contractility of the heart, contractility of the vessels. This happens to be a very important thing. We need to keep focusing on it. And here it is.
Which, by the way, Peter, all affects perfusion to the brain, which is what we want to focus on the most. So
boom.
Let's tie it all. That's the perfect way to tie it all together. Thank you.
Right. So this is kind of like the unspoken of element here of calcium. And it turns out that that in order to keep that blood bag on the right, so there's not clotting, they put in something called citrate. Citrate makes the blood not clot. How does it do that? It actually absorbs and chelates the calcium. So when you give whole blood to a human being, a live human being, it starts soaking up the calcium in that person. who's already hypocalcemic from the trauma. It turns out that whole blood has a certain amount of citrate. 1 unit of PAC cells has 4 times the citrate. So agencies who are using PAC cells over whole blood, they have a significantly higher calcium issue, and those folks are giving more calcium than the rest of us. So calcium is very important. What I would recommend is, again, you will not hear consensus on this yet, where it's some people are saying giving it after the first unit, some people after the second unit, some people say the third or the fourth unit. Between you and me, nobody knows, right? You have 2 options. One is calcium gluconate. You see there on the left. It's much easier on the vein. It doesn't, if it extravasates, you're not going to have that significant desiccation of the skin. And some people have lost limbs when it extravasates. So that's 30 per kilo in the, it's 30 mLs or 3 grams in adults. In kids, it's 60 per kilo. On the right-hand side, it's calcium chloride. You give 1 gram of that in adults, 20 per kilo in kids. And again, what I do at my agencies, we give calcium chloride, but how we do it is we actually dilute it in a 50 bag of saline and we let it run in slowly. So we're not going straight from the Bristol jet per se into the vein. Now, for TXA, it's 2 grams IV up front. Again, I do the same thing. We just put it into a 50 bag and let it run wide in. For kids, it's 15 milligrams per kilogram, and we max out at 1 gram in children. If you're going to go intramuscular, again, the dosing is higher. There's kind of dosing from the military on that, and papers have been published. But I would stick with 2 grams in adults, and I would stick with 15 milligrams per kilogram IV or IO in kids. What's on the horizon for TBI? Let me take the next 5 minutes to talk about what I think is the silver bullet. This is it, right? This is why I'm so excited about talking about it, but it's plasma. And let me explain to you why plasma, I think, is going to be the winner. When I show you a cross-section of the brain and I show you on the microscopic level, look how many vessels and look how many capillaries are sitting in there, because your brain needs a lot of blood vessels and needs a lot of oxygenation to actually feed it. So it's almost like a 1-to-1. That's how many capillaries there are with the neurons here. Very interesting. So there's not one cell in the brain that's more than 10 microns from a capillary. And that is so important when you're dealing with brain injury. Let me show you why. When you look at these capillaries, this blood-brain barrier, the brain is the one place where it 100% protects that blood from getting out into the brain, because the brain doesn't want to see everything that's coming through. So it protects it with a few ways. It's hard to see, but this capillary, this blood vessel here, has such tight junctions, very different from the rest of the body, because it doesn't want things leaking out of that blood vessel. Then it wraps the vessel in pericytes and astrocytes. It's almost like electrical wire. That's how well it's covered, right? The blood-brain barrier is a very unique place. Nowhere else in the body do you see that. Now, why is it important? Take a look what happens to this guy. Okay, he got hit right there. And let me kind of try and describe to you now what's really happening inside this football player's brain. I'm going to show you now a video where that injury just happened. And it's fascinating what they did here. They're showing that in those little capillaries, not only do you get leaks, but you get microthrombi, little blood clots. And then they infused saline with a blue dye on it. And I want you to see from a very minor, kind of, let's call it a minor injury, there's no big bleed on the CT scan. Watch what you're going to see here, how that saline ends up just leaking out of that brain because the blood-brain barrier has been disrupted. So you see here the number of seconds since the injury, 50 seconds, 53 seconds. And now what you're going to see here is you're going to see coming up here these little microthrombi right there. Look at that. They're forming inside the capillaries. And now if I pan out and I go 15 minutes, 30 minutes, now look at the saline that they're infusing. It's leaking out of those very tight junctions. The blood-brain barrier has been disrupted. And now 2 hours later, so now over the next many hours, that injury, like Mark said, that beautiful image of the sun, that penumbra, that area of brain that was salvageable, if you don't fix the leak today, right this minute, you're going to end up with penumbra that ends up dead. So the injury that was not a bleed on the CT scan, you're looking at it right here. So the question is, how do you stop the leakage right away? And that's really the fascinating part about plasma. So if I show you another video where the leakage happens, look what happens to the astrocytes. You start to get these astrocytes are accumulating all this inflammatory markers. Then all these neurons near there end up dying. You end up creating pathways that shouldn't have existed. You get seizures. And you have over time, very small areas of the brain that have neurons that have degenerated, all because of the fact that the leakage wasn't stopped at the very beginning. So what do we have to do? We have to stop the leak right away, not later, but in EMS. And how do we do that? So plasma is very important. Here's a rat model. This is a rat. It took a bunch of rats. Sorry for the rat lovers out there. They gave them the same brain injury over and over and over again. Half the rats they treated with saline, and look at the injury to that brain. That's all dead brain. And then the rats they treated with plasma, look at the difference in the brain. So by giving the plasma early, you prevented leakage, you prevented brain death, and now you have a patient with a better outcome who may walk and talk and do better again.
Peter, this is
So
such a good image for the idea of that element of brain that can survive in our hands or not, depending on the therapy we give. This is a beautiful image.
Yes.
Thank you. Yes.
And I appreciate you saying that, because now what is on us in the field of EMS, where nobody cares about what we do, they don't think that we even exist, we are the ones who have to now prove that plasma does this, that plasma prevents significant brain injury. To do that, Mark and Hillary, we are going to need to put our resources together. There's going to have to be an RCT, and not just a hospital RCT, but a pre-hospital RCT. And my team is actually looking at that actively, and I'll show you why in a minute. So if you look at the lesion size, again, the FFP is just frozen plasma, but again, just think of it as plasma. And you can look at normal saline and hextan, but you can look at what's happening with the plasma. Smaller lesion size, smaller brain swelling, and it's because it's fixing the leakage. Here's another great image. If you're blue, you have zero leakage. If you start getting hotter, yellow, orange, you have a lot of leakage. It turns out that even septic shock causes leakage. So why can't we use plasma for septic shock? Well, we can. What about burns? Leakage. We can use, what about anaphylaxis? It causes leakage. So it turns out that leakage doesn't just happen when you have a brain injury. It happens in the rest of the body when you have trauma and anaphylaxis and burns and all the rest. So it turns out that plasma may be the Swiss Army knife for more than just TBI. And that's, again, something that we're going to have to prove over time, hopefully, but before my career is over. So I love this image, because I was trying to think of myself, what is plasma really doing here in this image? And it's this guy. Plasma is the flex seal of your leaky pipes, okay? And all you're doing is fixing the glycocalyx layer that Mark talked about earlier, that inner layer of the vessel. The plasma is repairing it and fixing the leak, and that's where the benefit is. So let's get down to being more tactical here. I now, in my agency, thanks to my wonderful chief, Charlie Coyle, thanks to Dr. John Holcomb, who on the back of a napkin said, would you give plasma to TBI patients in Palm Beach County? And Chief Coyle says, of course I would. And again, there's a lot of animal data, 10 years of it, actually. There's human data. So this is not, we're not practicing on people. Plasma is being given in neuro ICUs today for these types of patients. And there's a randomized controlled trial. But what do? We basically, if we have a patient with a GCS of 12 or less, very simple. We give them plasma. We give them a unit. We look at their blood pressure. We use the LifeFlow. We give it to kids, right? We're giving the plasma a little slower here than we're giving whole blood. But at the end of the day, we are giving plasma in the field when the patient needs it to stop the leak. Speaking of the RCT, this is Dr. Hassan Alam. This guy is also a legend in the field of brain injury, a legend in the field of trauma. He kind of floats around with people like Don Jenkins and John Holcomb. So I got on a Zoom call with him, And I said, hey, I heard you're about to do a randomized controlled trial for TBI with plasma. He says, yes, it's taken me 3 years to get through the FDA. And I said, well, guess what? We're starting it in EMS. And this was a few months ago. I said, we're starting it next week. Guy almost fell out of his chair because he understands that EMS doing it early is probably where it's at. But this study is going to take 3 years. We probably won't see the outcomes for 4 years. I think the world is going to change very quickly between now and then, and I'll show you why. Because right now, today, you can go buy what's on the screen. I call it cold. That's actually frozen, fresh frozen. We're using cold liquid. You put out your hand to get your 2 movie tickets. They take your plasma, they put it in the fridge. They don't freeze it, and then they sell it to us in Palm Beach County. So in my blood cooler, in my Delta 2L, I have whole blood and I have plasma, and I'm giving it now for TBI trauma and burns. And I'm hoping to move towards sepsis and you can see here the ACE inhibitor induced angioedema and Coumadin. That's coming in the future. Now, just to finish off, I will say that there's more. And again, this is what we're using today, which is cold stored plasma or cold liquid plasma. However, there's something called spray dry plasma, which we think is going to become available next spring, where you're going to have a saline bag, empty, crystals in it, that does not allow moisture in. You take 200 cc's of sterile water, you infuse it, you shake it up together, and you have real plasma. Imagine having that in your pocket if you're a military person. Imagine having that in every ambulance. Imagine bringing that to any scene. 2-year shelf life, doesn't require refrigeration. This is going to change the game for all of us, not just for trauma, not just for TBI, but like I said, for sepsis, anaphylaxis, and burns as well. Just real quick, if you look at how it looks, you know, this is what it's going to come like. On the left-hand side, you'll have your bag of crystals, you'll rehydrate it, you'll have your plasma, and this is something that I really look forward to. And my last slide is, I'm so happy to say that our patient made an absolute full recovery. Why? Because he was treated with TXA. He was treated, actually, this guy got just whole blood at the scene. In this particular case, we didn't have the plasma yet. This guy's perfectly normal today. Who would ever thought? He flew 85 degrees in the air like a javelin, and he's a 25-year-old kid. So love being on the webinar with you guys. Love talking about this topic, and people can reach out to us, and I can't wait for the conversation we're about to have with everyone listening today.